this whole piece right now as we talk about changes. One of the things that comes to mind is about 53% of the deadlines and administrative pieces from the healthcare reform law have changed over time, and we'll continue to see changes. I'm going to talk about some of the changes as we go through this and try to really develop a timeline for the healthcare reform and what we've seen to date and what we can look at going forward. The healthcare reform law was signed into law March 23rd, 2010 by President Obama. The actual name, often referred to as Obamacare, is the Patients Protection and Affordable Care Act, often abbreviated as to the ACA. The intent on the law was really to broaden access for everybody, improve the healthcare system. I think one of the things that we see, and I talk about it both on the federal regulations and on the state regulations, is that Maine's been very progressive in our insurance laws. Maine has been guaranteed issue since July 15th of 1995. So we've had access to insurance for everyone. As you look across the country and you hear different rating factors, Maine has been unique in that you weren't able to be denied on pre-existing conditions. There was an exclusion for up to 12 months, but you were never denied. You weren't rated against based on claims history or health conditions. Other states that had those laws in effect are going to see a much bigger increase in their health insurance premiums because now they have to adhere to some of these new market standards that will start, really most of the big pieces have gone through for the 1st of January 2014. When I talk about pre-existing pre-existing insurance plans, we're really talking about grandfathered options. The grandfathered plans had to be in place back in March 23rd of 2010. In order to keep a grandfathered plan, a business needed to be able to keep the same benefit level and the same contribution levels. I don't think we've seen really any of our clients that have been able to do that. The contribution levels really have to change year to year, as does plan designs, as we've seen increasing medical trends. So I don't see really anyone in our book that is going to be continuing on a grandfathered plan. I think some of the thought was that those plans would go past them, but not the administrative issues as far as knowing what those would be at the time the law was passed wasn't clear, so most folks went ahead and made changes based on the economic needs of the plan designs, because we continue to see fairly healthy increases in the platforms. The donut hole for rebates for seniors, that was just, if anybody's seen the Medicare Part D programs, they're fairly confusing. They cover plans up front, they'll cover a certain amount of drugs, and then there's a gap in the middle of it. So this was one of the things to try to close that hole so that you didn't have to pay that extra piece. The other piece that we're seeing as far as one of the initial pieces of the law was the small business tax credit. The small business tax credit is an either-or scenario. So if I meet certain guidelines, I have to be under 25 employees, my average salary has to be $50,000 or less, I could take a credit of 35%. The problem, or what we look at with employers, is that you can take either the business write-off for the expense of your premiums, or you can take the tax credit based on earnings. Oftentimes, the straight business write-off would be economically better than the tax credit. I certainly refer folks to their accountants. This tax credit will go up next year, but you do need to be on the federal exchange in order to get that. So if you were to buy outside the marketplace, you couldn't access the federal tax credit. The early retiree grants, this is one that Lori, I'm going to pick on her, was very successful in helping us out with. It was really for folks between 55 and 65, so those folks that were retired but weren't eligible for Medicare yet. This was a grant where we were able to recoup some claims from the MDA Association. We got about $70,000 back and distributed that out to members based on claims that the MDA did pay for early retirees, so that was a real positive for us. The expanded coverage, and I think this is one of the popular pieces of the law that made sense for us. You were able to keep children on plans to age 26. Up to that point, I would have to be living at home, still be a student, typically to be covered under my parents' plan. Most coverages were up to age 23. The positive piece on this is getting those young adults to continue longer on those plans gave us extra premium for young, healthy folks. So for example, if I have an employee spouse and they don't have any children at home right now, but now they can add their child on the plan at age 25, they may pay an extra $3,000 a year in premium to have that family contract, but the typical 25-year-old is only going to use a few $100s in services. So from the insured standpoint, that really did help defer some of those costs. And again, for the job market, full-time eligible coming out of school, they weren't maybe with an employer that was going to give them full benefits, and this was a way to try to ride that time period out. Other part of the 2010 provisions, and again, one of the greatest pieces that I think that came out of the law was the 100% preventive care. The old adage of a pound of prevention is worth an ounce of prevention is worth a pound of cure really comes true with this. And what the legislation has said is that insurers must cover preventive care at 100% with no member cost sharing. So it does vary by age and gender, but for kids up through age 5, it's the scheduled pediatric visits, inoculations, immunizations. For adults, it's the normal routine screenings, glucose screening, lipid blood profiles. For women, annual OBGYN checkups, after 40 mammography screenings. And some of those were already included in the insurers depending on which company you were dealing with. But this really enhanced that benefit to make sure that folks were accessing that care at 100%. The rescission clause, which is kind of tricky, but the basics of it is that the insurers had to be very clear on their enrollment. If you're a small business owner and you saw some of the renewals coming out, you'd see them asking for a little bit more information each year at renewal. What the law said that is, if I'm, for example, I'm an insurance company and there's one of my employer groups that has an employee that hasn't worked there for 4 months, for example. That employer group's a small employer, they very easily can overlook that administrative change. It happens all the times in small groups. That employee that's no longer working there has a claim. At that point in the past, the insurer would say, we'd like to be able to audit that person, make sure they're still working for you, and then we'll certainly pay the claim. The laws changed that and said, if you don't catch that as the insurer and that claim comes about, you have to cover that. You can't go back and just pay the premium back to the group. So that's one of the reasons we're seeing a little bit tighter underwriting, both at the inception of a new plan and also at renewal. I don't think you're going to really see that as much going forward because, again, as we look at January 2014, some of those underwriting rules will change completely regardless, so it's not going to be as big of an impact. The elimination of the lifetime dollar maximums, and again, that really said any of the insurers had to have an unlimited maximum. There are a few exceptions to that, things like, for example, certain number of visits, physical therapy, speech therapy, chiropractic care, durable and medical equipment had limits. But typically when we think of things in a hospital setting, that lifetime maximum was removed. I can tell you that when I worked for the Blues, which was several years ago, we used to see a common maximum was $3 million, and no one in the history of Blue Cross at that point had gone over that. But we're seeing now where claim costs and hospital costs certainly are going up, and that removal of that lifetime maximum certainly is helpful for some folks moving forward. No pre-X for children under 19. That's another one. So if I had a child that hadn't had prior coverage, and keep in mind, if I'm moving from one plan to the next, in Maine it's been like that for a number of years, and since HIPAA's passed federally, if I have an insured plan and I change jobs, as long as I don't have a gap in coverage of more than 90 days, then no pre-existing conditions would be imposed. This intent was really if I had a child that was uncovered, had not had coverage for more than 90 days, I add them onto my plan. At that point, that child's no more pre-existing condition. So that was one of the early changes on the pre-X clauses, and we'll see that with adults as we move forward. Preventive care and chronic illnesses, there were a number of grants that came out that were awarded through the Department of Health and Human Services, and most of them were to improve access. With Maine, a lot of it was for rural access, but also for some clinics throughout the state. That was just part of the initial grants going through. The prescription drugs for seniors, that was another enhancement that we saw go through. They were just trying to improve that. The Medicare Part D, when it was originally passed back in 2003, had some real limitations to it. So this was part of the law was to fix that as well. So for seniors, we are seeing better prescription drug coverage. Medical loss ratios, I haven't seen anybody, I'm going to put Lori on the spot. I think other than we've had some from Cigna, but medical loss ratio is basically claims versus premium. So what they're saying is for insurers that if the amount of premium taken in versus the ratio of claims are paid meet a certain threshold, we expect a rebate to members. Now again, we haven't seen that for most folks here in Maine. We've had a couple of clients within the Cigna platform that we have seen with those rebates that have gone back. The rebates go back to everybody that's in the membership, so it's not back just to the employer. They try to look at everybody within the plan, and they want to be able to break that up consistently amongst that group. It does mention the tax penalty, but I'm going to talk a little bit more about taxes. I have actually 2 slides that talk about some of the fees and taxes specifically, so I'm going to kind of address those throughout that slide. The 2012 changes. The individual plans, these are new summary benefit coverage descriptions. They're a lot like what we've seen in the past, which is usually a 6-page overview of the benefits that tries to explain what your deductible is, what coinsurance is, what a copayment is. I think the problem, and I think everyone sees this, is you almost need a linguist or a translator with most insurance documents because they have their own speak. I still today, and see that on every group that we go out and do enrollment meetings with, is to walk through what the difference is from a copayment. How does a coinsurance work? So what the federal government has said is we'd like to see a consistent summary benefits description for each plan so that consumers can look through and actually do a nice side-by-side comparison. The other thing that we've seen, and I'll talk about in compliance, is the onus is on the employer, the plan sponsor, to make sure that those are delivered in a timely basis. And there is a fairly hefty fine if you don't distribute those in a timely manner. So it's within 7 days of a new hire, and it's during your open enrollment, so that month before your plan does start. So it's important to get those done. The other thing is if you don't have that information, you need that, certainly address that with us. It's very easy that you can distribute it electronically. I typically have folks put it in the break room, offer it in an open enrollment, and then also make that available through an email distribution. Another part of the effective August 1st of 2012 was the women's health mandate. They've just increased the benefits to women. Contraceptives were now put into a 100% preventive care mode, as well as it increased things like prenatal screenings at 100%, breastfeeding supplies, counseling, pumps, and also a voluntary sterilization. So for folks that were looking for that, that now becomes a 100% preventive care item that's not any cost sharing whatsoever by the member. For 2013, the increased access to Medicaid hasn't happened in Maine. I'm sure most of you have heard that. It's the increase of the federal poverty limit. The governor, and I'm going to try to stay as far away from politics as humanly possible when it comes to this, but the governor has been looking to not increase access for Medicaid. The legislature has wanted to. The federal guidelines are 133% of the federal poverty limit. The concern that we've heard from the state level is that the federal funds are only going to go for so long. They were going to pick up 90% of that cost immediately, but then after the fact it would be up to the state, and they were very concerned about budgeting that, with already some concerns with the Department of Health and Human Services locally and some of the budget issues they've had with that department. The additional funding for the Children's Health Insurance Program did go across federally, so we did see that increase. And the threshold, and again, I'll talk about taxes, but what that is for adjusted gross income. If I had unreimbursed medical expenses, I used to be able to write that off if it was 7.5% of my adjusted gross. They've increased that to 10%. Again, kind of a hidden tax because it does increase tax revenue to the government for folks that do have unreimbursed expenses.